Now let's talk about the drugs. So usually we put the antipsychotics into two buckets and call them first and second generation, so the older and the newer ones. Some people talk also about the typicals and the atypicals, but this nomenclature has fallen out of favor. So for the first generation, I would remember haloperidol. That's certainly the most famous one. Haloperidol as an example for a first generation, and there's tons of second generation, so you probably need to remember some. So I would go for quetiapine. I would also remember olanzapine, and actually a lot of the second generation, and on apine. There's also a very famous one which I'm gonna do with a different color because it's very special and we need to talk about it separately. It has its own characteristics. It's clozapine, but it comes up a lot. And then I will also talk later about another second generation that is also different, but we need to also discuss it. Things like aripiprazole. There are more piprazoles. Aripiprazole, brexpiprazole. So what differs between a first and a second generation? Well, the mechanism of action. The mechanism of action of most of the antipsychotics is D2 antagonism. So they are antagonists on the D2 receptor. And I'm going to write this here also because that's also true for those guys. Again, we're going to take aripiprazole a little bit separate. And then in addition, the second generation have another additional mechanism of action, and they are also antagonists at the specific serotonergic receptor, at the 5-HT2 receptor. So now, what is the problem in schizophrenia? Well, it's very complex, but one thing we know that there may be too much an excess of dopaminergic signaling in the mesolimbic pathway. So now there are several pathways where we find dopamine, but this mesolimbic pathway, there is excessive dopaminergic activity. And that's what you're going to block with this dopamine antagonism. And that's why those are all antipsychotic. And it turns out this excessive dopaminergic activity is mainly responsible for the positive symptom in this mesolimbic pathway. So in a nutshell, we know that all the antipsychotics are dopamine antagonists. And why do we want that? Because there's too much activity in the mesolimbic system, and that's when we block it, we get this antipsychotic effect, mainly blocking these positive symptoms. And that's why we use them. But we know we can't tell a drug, okay, you're only going to block dopamine receptors in the mesolimbic pathway. No, this is not going to work. So the drug will block all kinds of different dopaminergic pathways. Now, dopamine we understand fairly well. We know what dopamine does in different pathways. So we can now predict what's going to happen when we block dopamine in different pathways, like the nigrostriatal pathway. And it turns out, well, the nigrostriatal pathway and dopamine is very important for movements. And we know even a disease where we lose dopaminergic neurons in the nigrostriatal pathway, which is Parkinson's disease. So it should come not with surprise that when you take a dopamine blocker in a patient with psychosis, that you're going to resemble Parkinson's disease because you're going to just block the receptors in this nigrostriatal pathway. And we call this all the motor symptoms that you're going to experience as a side effect. You can call them motor symptoms, but in the medical term they are called EPS for extrapyramidal symptoms. So all kinds of motor problems that the patient is going to experience on a dopaminergic blocker. Now the tuberoinfundibular pathway, we find there also dopamine, it's more an ERM topic. So in this pathway, dopamine inhibits prolactin. Now, well, if you have a dopamine blocker, you're going to get more prolactin. We can say, well, the patient is going to experience hyperprolactinemia. And how does this present? Well, with milk flow from breast, so that's called galactorrhea, but also with other symptoms, such as menstrual irregularities, gynecomastia, decreased libido. So that has all to do with hyperprolactinemia. And these are the adverse effects, so these two, this is the wanted effect, that you can directly relate from the dopaminergic blockade. Now, I also want to mention that these dopamine blockers were not developed as such, so they are quite dirty drugs. What does it mean? It means they have a lot of off-target effect. In particularly the first generation. They also block, so we're still with adverse effects. So one is dopaminergic blockade, but then they also block H1, alpha-1, and muscarinic. So this is also sometimes referred as the ham blockade. And we know what they do. When you block histamine, you get weight gain, you get sedation. When you block alpha-1, you get hypotension, particularly orthostatic hypotension. What are you going to get when you block muscarinic receptors? Well, dry mouth, constipation, urinary retention, blurred vision. So that are the typical muscarinic effects. So this is more for first generation because generally they are only dopamine blockers and they have then off-target effects. They have additional effects like the serotonergic antagonism, and we're going to go there next, what that has as a consequence. So in terms of adverse effects for the second generation, we also need to consider the 5-HT2 antagonism. So they are dopamine blockers, so this can happen. But then we have in addition also 5-HT2A antagonism. And when you block this receptor, you can experience metabolic syndrome. And that's obviously not a wanted adverse effect because that means weight gain, high blood pressure, high blood sugars. So you're going to increase your risk for cardiovascular disease, stroke, and diabetes. So let's just summarize what we learned so far. So we have first and second generation. They are all dopamine antagonists, but the first generation relies completely on the dopamine antagonism. And for the second generation, we have an additional mechanism of action, which is this 5-HT2 antagonism. They are generally weaker dopamine blockers. Well, because we are using dopamine antagonists, we have all kinds of motor symptoms that I'm going to explain in a second. They are called EPS for extrapyramidal symptoms. And generally, because they are weaker dopamine antagonists, the EPS in the second generation is lower risk, but we are adding an additional adverse effect, which is metabolic syndrome, which is probably related to this 5-HT2 antagonism. And then generally they work all pretty good against the positive symptoms, but for the negative symptoms there's only very, very few good drugs, and they can be found in the second generation and not in the first generation. Now I want to talk more in detail about this EPS, all kinds of motor problems that you see due to the dopamine blockade of the nigrostriatal pathway. So extrapyramidal symptoms, we can distinguish between acute and chronic ones. Acute that come fairly quickly, and here we have three different ones, and I put them in the order of appearance. So acute dystonia is basically an acute muscle spasm that you find usually in the neck area or in the eyes. This can happen really hours after administration. Then the next one that you can see within days is akathisia, which I always like to describe as the ants in the pants. So that's like an overall body restless leg syndrome. So some of you may have experienced restless legs. So imagine that's something over the whole body. So you have this urge to move. That's akathisia. And then Parkinsonism. So, well, that already tells you, ism always the ending tells you resembling a disease. It resembles Parkinson's disease, and that's within weeks. And that's exactly how Parkinson presents. So, bradycardia, slow movements, rigidity, so the stiffness, and then also the tremor. So it's really resembling Parkinson's disease. Now those we can put under the category of acute EPS. And it's nice to put them together. And then we have one that is also sometimes referred as late or chronic EPS, and that's tardive dyskinesia, and that can happen years later, years after chronic administration. And so tardive stands for late, kinesia movement, dyskinesia, so kind of an odd wrong movement, and it's mainly seen in the orofacial area. And you see some repetitive movements in mouth, face, and that's tardive dyskinesia. Now I want to talk a little bit more about acute versus late, also in terms of treatment and in terms of mechanism. So for the acute EPS, it's fairly straightforward. So this is due to dopamine antagonism. So now imagine you have a patient coming in with one of these symptoms or with all of them. How can you help? Well, because it's due to dopamine antagonism, you could reduce the dose. One option. But then you also have probably more antipsychotic symptoms again. But there's another option if you're thinking about how to treat Parkinson. Well, we know in this nigrostriatal pathway, there's usually this balance between dopamine and acetylcholine. Now, if you block dopamine, well, you have too much acetylcholine. So what we can do is give a antimuscarinic. So that's antimuscarinic drug. So I'm going to write this here again, antimuscarinic. By just blocking acetylcholine. And this is done with benztropine. And I mean, the poor man's version, you could also just use Benadryl. So diphenhydramine, because it has also antimuscarinic properties. But benztropine is another option. Now, so this is treatable. Now, it's way more complicated for tardive dyskinesia because it's probably due to the dopamine receptor, particularly D2, hypersensitivity. So the idea is if you take now this dopaminergic blockers for a very long time, the dopamine receptor will upregulate. And that's probably the reason for tardive dyskinesia. So you can imagine it's not going to help to reduce the dose. It may even make it worse. But there are now treatments for tardive dyskinesia. And one of the treatment is a drug called valbenazine. It's a VMAT2 inhibitor that can be used to treat tardive dyskinesia. But unfortunately, it's a lot of times irreversible and not necessarily very well treatable. But I'm just going to write valbenazine there is one of the treatment options for tardive dyskinesia. Now, another word about something else that you can see and that's sometimes referred as rare EPS because it happens very rare, can be fatal, dangerous, and it's also not really clear in terms of the mechanism, but you should have also heard about this adverse effect, and that's called NMS, which stands for Neuroleptic Malignant Syndrome. Now, how does somebody present with neuroleptic malignant syndrome? Fever, rigidity, autonomic instability, which means blood pressure and heart rate go all over, and delirium. So this is can be a potentially fatal syndrome. And if you hear the symptoms, you may think that sounds a bit like serotonin syndrome, and that's absolutely correct. They're very similar. Now, for board questions, I would really look at what the patient was taking. This is called neuroleptic malignant syndrome because the antipsychotics once back in the days were called neuroleptics. And so if you have a patient with fever, rigidity, high blood pressure, and delirium that has a history of schizophrenia and was on haloperidol, well, then it's probably NMS. If you have a patient that is on several drugs that increase serotonin level, then it's probably serotonin syndrome. So that's how I would tackle such a question.